So now we are going to discuss another critical care station, TAP block and local anesthetics. So TAP block is basically transversus abdominis block or transverse abdominal plane block. So if you remember the anterior abdominal wall muscles like uh, the layers, for example, this is external oblique, internal oblique, then we have the transverse abdominis. So this plan here, we have the intercostal muscle nerves. So you have to target this in TAP, but which one? So basically, let's suppose if we draw this in cross section like this. So let's suppose this is the transverse abdominis, this is internal internal oblique. So here in the upper portion are the T1 to T6, and then downward we have the T7 to L1, which is ilioinguinal, and L2 iliohypogastric. So you have to target these T7 to L2, because if you target these you will kill the patient of respiratory failure. So you have to avoid this. And if you remember, or if you see the it can happen if you watch the epidural video. There is the patient which has high epidural block, so he is desaturating and like suffering from this neurogenic shock. So coming to the topic, so we have why COPD patient on apexaban has severe abdominal pain, going for emergency laparotomy because of sepsis. He is febrile, hypotensive, and tachycardic. Now what to do? You cannot give him anesthesia, GA, general anesthesia, because of the risk factors. You have this COPD, and you have apexaban, and also there is decreased blood pressure and tachycardic. So everything is in opposite. So you cannot give general anesthesia. So why epidural is not ideal in this patient? So you cannot go for epidural as well. Why? Because of the apexaban. So if patient is on apexaban, which can cause bleeding hematoma in the spinal canal, and it will compress and will damage the spinal cord. Patient has COPD, high epidural can block intercostal nerves, ICN, and hampers respiration. You will kill the patient. Already he is compromised. What other options can be done for this patient? Regional block, TAP block, rectus sheath catheter. So IV anesthetics, IV anesthesia like propofol induces bronchodilation in COPD patients. Okay, so induces bronchodilation in COPD patients, and thiopental etomidate safe in COPD patient, no direct bronchodilating effect. But ketamine bronchial smooth muscle relaxant. So you can give this anesthesia, IV anesthesia as well. Inhalational halothane, sevoflurane, both dilate airways, but use of halothane is limited because of the myocardial depression and hepatotoxicity. Ketamine is a very good anesthetic. It can maintain the BP and vital stability. Etomidate is the adrenal depressor. It depresses the adrenal gland. And yes, so what will prevent you to use morphine for pain in this patient? So respiratory depression can occur. Already he is COPD patient. What are the post-operative options for pain management? I will use WHO stepladder for pain management first. If not, then I will consider regional block like rectus sheath block or TAP block, and local anesthesia and filtration 0.5% bupivacaine. But first I will go for WHO step ladder. What is step block, how it is given? So I already discussed that this is internal oblique, and here is the transverse abdominis, and you have these nerves here. So you will go for G7 to L2, so it will cover your tummy, so you can operate anywhere. So transverse abdominis plan is an example of facial plan block where local anesthetic is injected in the facial plans containing the nerves from abdominal or for abdominal or chest wall structure. The T1 segmental nerves enter the plane between the internal oblique muscle and the transverse abdominis muscle, just medial to the anterior axillary line. Injection of local anesthetic, preferably bupivacaine, into the facial plane between the internal oblique and transverse abdominis muscles allows a block of all these nerves and an excellent anesthesia of the anterior abdominal wall. What are the systemic side effects of local anesthesia? So CNS, agitation, confusion, lethargy, circumoral slurred speech, first sign. Slurred speech is the first sign. Dizziness, drowsiness, dysphoria, and tinnitus. Respiratory depression, cardiac arrhythmia such as sinus bradycardia, conduction block, asystole, VT, and sudden death. So this can be the cardiac effects, and methemoglobinemia in case of Proleukin. Proleukin can cause methemoglobinemia. Why local anesthesia can't function in the abscess cavity? In inflammatory condition, the surrounding area's pH which eventually decreases. pH decreases in acidic and abscess cavities. So which eventually decreases the amount of base form of local anesthetic penetration into the nerve membrane, thereby causing anesthetic failure. So this anesthetics can go or work properly in basic environment. So they that is why it is sometimes that people inject sodium bicarbonate to increase the efficacy of anesthetics. So here simply you can say abscess can cause acidic environment, and local anesthetics cannot work better in acidic environment. This is simple. So thereby causing anesthetic failure. In such condition, the excitability threshold is reduced, leading to failure in achieving anesthesia. So why? First is that anesthetics cannot work better in these acidic environments, and second is that excitability threshold is reduced, so you will feel pain anyway. How will you manage local toxicity? Local anesthesia toxicity: immediate, stop the infusion, CCRIS protocol, ventilation, ABC. ABC. So ventilation, low flow oxygen in this patient is COPD. Why low flow oxygen? Because if you give him normally we give high flow oxygen to normal patients, but in COPD patient, if you give high flow oxygen, it will suppress the respiratory center. So COPD patients are dependent on the central drive for breathing. So if you give him a lot of oxygen, it will suppress the center, because it will say that oxygen is available, so it will not activate the respiratory movements, so it will further worsen the condition. Circulation, gain IV access with 2 wide bore cannulas, control seizures using benzodiazepines, thiopental. Okay, so what is the definitive treatment? So these were the supportive treatment. Now what is the definitive treatment? So definitive treatment: give him bolus IV 20% lipid emulsion intralipid 1.5 ml per kg or 1 minute. 1.5 ml per kg or 1 minute. Give him this bolus. And maintenance is IV infusion of 20% lipid emulsion at 0.25 ml per kg per minute for 15 minutes. Sorry, for 1 hour. 15 ml per kg for 1 hour. Yes. In ml we have 0.25, like 1.5 here. So 15 ml per kg per hour, you can give him this intravenous infusion of 20% lipid or intralipid emulsion. So here we have immediately you have to give him bolus, the same dose, and then after 5 minutes, if no cardiovascular response or continuing deterioration of circulation, repeat the bolus for twice. So initial one and twice more, so it will be totally of 3, including the initial. So you can give this after 5 minutes as well until the patient get better. What is the safe dose of lidocaine and bupivacaine? So the safe dose of lidocaine is 3 ml per kg or 7 milligram per kg with adrenaline, and 2, it is same for both with adrenaline, without adrenaline 2 mg, because it is so toxic. Prilocaine is 6 mg per kg, 9 mg per kg with adrenaline. Ropivacaine 3 to 4, and levobupivacaine is 2 milligram per kg. So here early common side effects: early onset, short acting and good sensory block, and bupivacaine is very toxic. It can cause irreversible malignant arrhythmias. So long lasting, more toxic, never be used intravenously. Don't use it intravenously. And prilocaine is least systemic toxicity, causes methemoglobinemia, less cardiotoxic, greater sensory motor response, and motor separation. Levobupivacaine is isomer of bupivacaine with fewer side effects or fewer cardiotoxic properties. How will you calculate the dose of anesthesia? So you maximum dose allowed like this: mg per kg into body weight, and then divided by given concentration, of local anesthesia. For example, it's either 0.25% or 1% or 5%. So here will be the concentration multiplied by 10. Okay, so here we have this. If solution concentration is 0.25%, so you will have to 0.25%, 10 ml will be equal to how much? So you can calculate this as that you can calculate it. I will put this on channel, inshallah, this calculations.